generation 1 through 19, bronchoconstriction. All right? And then whether it be mast cell degranulation or inflammation, either one can produce excessive secretions. Does that make sense?
Yes.
Yeah.
Okay. All right. Everybody ready? This is easy today. Spread eagle. You know what that means. Anaphylaxis looks like asthma. It's due the 21st. Yes. And they need to be typewritten. And tell me, I understand it, I thoroughly enjoyed it, this is Greek, whatever you want to tell me.
How long basically?
I just told you, 1.5 to 2 pages long. It must be typewritten. You do not need a cover sheet. Just make sure your name is on it. But if you want to do a cover sheet, I know some people are visual, and you need that. So however you want to do it. Yes, ma'am. I can't hear you. Double space. Double space. All right, so that's 3 articles. And this is going to help you. This is helping you to understand why you, as a respiratory therapist, need to know about 3,5-AMP and 3,5-GMP and alpha, beta 1, and beta 2, yes? And it also is going to help you understand why we need to educate patients so that they can take their medication correctly. Okay? So you got 3 articles, the 24th, the 7th, and the 21st. Everybody got it clear? All right. Have fun. Someone gave me these, and I said, well, isn't this just perfect? And you know what? This was written in 2011. It still stands 2013. All right? Okay. I have Blackboard up, but we're going to work through it. You have your ABGs?
Yes.
All right. Kendra, number 1.
Oh, can I do number 2?
Ganya, number 2.
No.
Catherine, did I call on you? No. I didn't. Number 3.
If I'm ready, I want to answer.
Did I call on you last time? Number 4. Maybe I'll turn this off on you guys. Here. What number do you have? 1. What number do you have? 2. What number do you have?
I'm okay. Number 4.
So you have number 3. And we know that that means that pH is not in range. That's the whole thing about a blood gas. Where is that pH? Because if the pH is out of range, it's doing something. When this blood goes to the tissues, it's doing something. And it causes a lot of abnormalities and pathogenesis.
And if it's normal.
If it's normal, either it's a normal blood gas or the blood gas is compensating.
Okay. Thank you.
Okay. Any others? Okay, you're up here. You can explain yours. Go ahead.
I'm off. I'll be honest.
Why?
I need more practice. Because I know, this is on the acid side of normal for the pH.
What's normal pH?
I'm sorry, what was that? 7.35 to 7.4.
We'll call it correctly. All right. The more you do it, the more proficient you become. And I don't believe in, and this is for everybody, don't tell me you can't do it. Why can't you do it? Sure you can do it. You think you can't do it, you won't.
No, I need more practice. I won't.
Do it.
PaCO2, 62. It's close to the normal range. but
What's
not very high.
normal?
80 to 100.
No, it is not. PCO2. Where are your notes? Where's your handout? Go get it. I don't know if you all paid any attention. This is my little dendrite up here. This is a neuron.
Oh.
That's what it is.
I
That's a
couldn't
little
figure
dend-
that out for
That's a dendrite. That can be parasympathetic or sympathetic. Anyway, it used to be real soft. Now it's hard.
Dried out.
Yeah, but it's stuck, so we're just gonna leave it. All right, what's a normal PCO2?
I'm trying to find it in my,
Where's your handout?
I don't know what I have the notes from the other day, I don't have.
Don't come to my class unprepared. Find your notes. What's normal? We can't go any further. Are you willing to share? Thank you.
Absolutely.
Thank you.
Make sure you give it back to Rachel. So what's normal PCO2?
$80 to 100.
PCO2.
I'm sorry. 35 to 45.
Okay, so anything greater than 35 is considered what?
Acid.
Put an A up there. What's normal bicarb?
22 to 26.
So what is 25?
Normal,
Okay.
but on the base side.
No, it's
we're doing-
normal.
Okay. Is the only one that we're doing normal that on the pH?
And then you don't have to worry about
Because
normal
that-
on the acid or the base because it is indeed acid because it's less than normal.
And that reflects that.
Uh-huh. All right, so what's the primary problem? Is it respiratory or metabolic? Kidneys or lungs? Which one is off?
It's lung.
Okay. And so the pH matches what?
The PaCO2.
So what do we call a PCO2? Respiratory or metabolic?
Respiratory.
Write that down.
Acid.
Write it down.
Yeah, right with this one.
So it's respiratory acidosis. Now that pH is not within normal range. So is this an uncompensated pH or a compensated pH? What does uncompensated mean? Can we give Rachel her handout back? Thank you. What does, thank you. What does compensated or uncompensated mean? Look in your notes. We're waiting on you.
I know.
Okay. Let's go to number 2. Who had number 2? We'll come back to number 1.
The pH is, I don't know.
Come on.
Okay.
Gotta go to the front.
Jonathan had to come up here. You have to come up here. Right, Jonathan?
So pH is normal, but
Keep going. pH is normal. Keep
okay.
going.
Partial carbon dioxide is towards the base side,
Base. Good.
and bicarbs are towards the acidic side because
Right.
the normal is 22 to 26, or below 22.
Good.
And B is negative 4.5, so it's towards acidic.
Uh-huh.
So this pH is towards the base side,
Okay.
so that's why it matches the lungs.
Mm-hmm.
So, and it's normal, so it's compensated respiratory alcohol.
Very good, very good. And what we have here, in a compensated blood gas, we have a normal pH, and we have two conditions, everybody. Thank you, Donnie. We have two conditions. We have base and an acid, right? So always remember, in a compensated blood gas, you're going to see three things. One, you're going to see a normal pH, and then you're going to see the lungs and the kidneys opposite. It doesn't matter which one, but they're going to be opposite. So when I say opposite, one is going to be acid, one is going to be base. And we see all three, right? Yeah. So I know this is a compensated blood gas. Everybody with me? Mm-hmm. Then I go back to my pH and say, is it on the acid side of normal or on the base side of normal? And that will help me determine what my primary problem was. So Ganya said the pH is on the base side of normal, so I know my primary problem was respiratory alkalosis. Nice. But now that pH is compensated, so it's compensated respiratory alkalosis, right? Very good. Okay.
It's uncompensated because anything within not normal pH is uncompensated.
Thank you. And you said you couldn't do it.
No, I just had to fight.
Uh-huh. Have you been doing this at home?
Sort of.
Uh-huh.
I know, I need more practice.
It's on you, dear.
I know.
All right, number 3.
pH of 7.51 is obviously higher than normal, so that's going to be a base. The PaCO2 is at 40. That's in between the normal range of 35 to 45. That is normal. The HCO3 or bicarbonate is higher than 22 to 26. That's going to be on the basic side. And this is obviously a base because it has the positive. So uncompensated because it's not within normal range. Metabolic right here, the alkalosis.
Very good. All right, next.
Okay, the pH is normal because it's between 7.35 and 7.45. PaCO2 is higher, so that's an acid. The bicarb is higher, so that's a base, and the VE is higher, so that's a base. And because it's the pH, or because it's between 7.35 and 7.39, it's an acid. So that's compensated respiratory acidosis.
Very good. Or she could call it chronic respiratory acidosis. So Kyle, was your question answered? Okay. Any other questions? Okay, let's move on to pharmacology. Very good. Now remember, I haven't given you the PO2s yet. This is just acid-base. We haven't, after we get further along in Module 2, we'll add PO2s to this, okay? All right. You guys are coming along just fine. Some of you whippersnappers, you all finished that quiz in 5 minutes. Wonderful. You got it? I see helium heads growing. Do you know how much you all have learned in 3 weeks? But it's the more you do it, the more you see it, the easier it becomes. I promise you. I want you to go to page 10 in your text or page 5 in your workbook. Either one or both, doesn't matter. Page 10 in your text or 5 in your workbook. In your workbook, it's number 35, and on page 10, it's the top table 1 through 4, 1-4, dash 4, whatever. Okay. First thing that I want to give you, we're moving along. You understand fundamentally, and I'll know for sure once I correct this quiz, but fundamentally we're understanding PNS, SNS, because the drugs that we administer mimic either the PNS or the SNS. There will be other drugs you will learn, but we won't administer them. Okay? Yes, the beta-1 drug we don't administer, but you need to be cognizant if your patient's on it. You're going to learn about sedatives. You're going to learn about muscular blocking agents. But we as therapists won't administer it. You're going to learn about insulin in a diabetic. We as therapists don't administer insulin, but you need to understand what's going on if that is administered. But on page 10, and then it's somewhat incomplete on page 5, but you can certainly transfer the data. These are the drugs, the 7 drugs. One of your student learning outcomes, I don't know which one, but one of your student learning outcomes says identify the 7 aerosolized drugs in respiratory care. All right, the first group are the adrenergic agents. What is adrenergic? Where did that term come from? S&S. Now you know, don't you? Now what if I just said, I only told you that the drugs we administer are bronchodilators. If I had just used that term when we read adrenergic there, you would have been lost, wouldn't you? Now you know what adrenergic is. So if we, as respiratory therapists, administer adrenergic drugs, do we administer beta-1 adrenergic drugs? No. What beta do we administer?
Beta 2.
Do we administer alpha drugs?
No.
We administer what kind of drug?
Beta 2.
Beta
You can
2.
write it down if you want to. Now you know an adrenergic drug in reference to respiratory care is a beta 2 agonist, yes?
Yes.
See the synonymous terms? See it, Kyle? Yes, ma'am. All right. All right. Therapeutic purpose, it tells you there. And look at some of the drugs. Some of these drugs, for your drug cards, you're going to have to identify trade name, generic name. These are all generic. All right. The next group are your anticholinergic drugs. Is that PNS or SNS? PNS. Is it an increased 3,5 AMP? No. Or is it a decreased 3,5 GMP?
Decrease.
And it's synergistic, right? Now you know. That's your second classification of drugs. Now the others, we haven't gone through, but I want to briefly go through them so you can read this. Mucoactive drugs. This is a drug that it doesn't have anything to do with the SNS or the PNS. Remember I told you that one reason why a patient wheezes is excessive secretions? Mm-hmm. Well, what you're going to deal with is patients, and I just use this, they're going to have fur balls. They're going to have mucus plugs. I got Kelly laughing. They're going to have mucus plugs, and they're not going to be able to expectorate. When I say expectorate, what am I saying? Cough up.
Cough up.
They're not going to be able to. The secretions are there. We're going to hear them with our stethoscope. But when they cough, they can't move the secretions. Those are called mucus plugs. Mucus, M-U-C-U-S, plugs, fur balls. And so this classification of drug is called a mucolytic. Muco means what? Mucus. Lytic means what? Block, stop, inhibit, break down. So a mucolytic breaks down thick secretions. What does a mucolytic do? It liquefies it. So it'll take a mucus plug and liquefy it. And then as the mucus plug is liquefied, what can the patient do? Cough it up. Make sense? Yes.
And a mucoactive is not SNS or PNS. It's
Nope.
something different.
Something different. It doesn't work on the SNS or PNS. Got that? All right, that's mucolytic. Then corticosteroids. One reason a patient wheezes is what? Mast cell degranulation. Another reason a patient wheezes, we said, is excessive secretions, right? Yes. Mm-hmm. And what's the third reason?
Inflammation.
Inflammation.
There you go. Corticosteroids. Corticosteroids. Corticosteroids are anti-inflammatory drugs. It reduces swelling. And so you will administer synergistically. And a couple of those drugs I have up there, I don't think they're in 5 through 8, but for next week's drugs, 9 through 12, a couple of those drugs will be beta-2 agonists and corticosteroids. And that's a common type of drug. Somebody told me, it was in this class, yeah. Somebody said that who told me yesterday or day before their baby had croup or whooping cough? Somebody said that.
My daughter.
Okay, yeah. Your daughter, and what did you say they gave her?
They gave her some sort of cough medicine, but they said it had corticosteroid.
It had a corticosteroid. So her croup was actually laryngeotracheal bronchitis, but we call it croup in the babies. Her airways were inflamed. And because her airways were inflamed, not only did it cause a small amount of wheezing in her bronchi, but it irritated and inflamed her throat and her larynx. Okay? So they gave her a corticosteroid solely because she wasn't wheezing, and it reduced the inflammation. But how old is your baby?
Now she's 4. She was 3 when she.
Baby. Because she was a baby, she had to have it in liquid form. So corticosteroids are anti-inflammatory drugs. And so now you understand the 3 reasons why a patient will experience bronchospasms. One, we've gone through mast cell degranulation. And the second is inflammation. Anytime the airways are inflamed, we can give them the bronchodilator. That may stop the wheezing. Does that make sense? But it's not going to stop the inflammation. So they have to have a corticosteroid that has what does anti mean? Against. Inhibit, block, prevent. So they have to have an anti-inflammatory drug to reduce the swelling. Make sense? All right. And so will administer those drugs. And a couple of drugs that will administer, it could be to children or it could be adults, will be a beta-2 agonist and a corticosteroid. And they can be administered synergistically. One will take care of the bronchospasms, and the other will take care of or reduce the swelling. Make sense? All right. So that's another classification of drugs. Then the next is anti-asthmatic. Anti means what? Against. So this drug is not PNS. This drug is not SNS. But we say anti-asthmatic because this is the drug an asthmatic needs to be taking at home every day, even when they feel good. And you know what these type of drugs do? They prevent mast cell degranulation. Now we're talking about drugs, and I don't have to explain what mast cell degranulation is. They prevent mast cell degranulation. So I'm going to go back and use 2 terms. Remember up here earlier, I was talking about short-acting, the beta-2 agonists. Those are called rescue drugs. I'm wheezing. I'm in bronchoconstrictions. I got an increased work of breathing. I'm using my respiratory, my accessory muscles. They are called rescue drugs, short-acting. I'm going somewhere with this. Short-acting. Give it to me right now, and hopefully it'll work. All right? Short-acting. However, this group of drugs that we just went through, the anti-asthmatic drugs, they're not rescue drugs. They're called controllers. Controllers. And so what are you saying, Kathy Miller, in your madness? I'm saying if a patient does begin to wheeze, everybody with me? They have to stop taking this drug because it's not going to work anymore. And then they have to have a rescue drug. Because these drugs are not beta-2 agonists. These drugs just prevent mast cell degranulation. But if for whatever reason mast cell degranulation does occur, it's not going to stop the patient from wheezing. Okay? So beta-2 agonists are rescuers. I'm wheezing, I'm having an asthma attack, or I'm wheezing for whatever reason, give me a beta-2 agonist. But for the asthmatic, after we get them out of the acute exacerbation and get them on their merry way, they go home, they have to take controller drugs. And our responsibility is to educate them, even on a good day. Take this medication. Be compliant. It will prevent you from wheezing. But if you start wheezing, this drug is not effective. Got it?
Is it not effective ever then? Is that what you're saying?
No, no, no.
Okay.
During the wheezing.
Just during the wheezing?
Just
Okay.
during the wheezing. Then they have to have the rescuer drug.
Okay, great. Thanks.
Okay. All right. Any questions?
And the reason why it's not affecting at the time of asthma attack?
It's not a beta-2 agonist.
Because it takes time. Long.
No, it's not a beta-2 agonist. Only beta-2 agonists increase 3,5-AMP. This drug is not a beta-2 agonist.
So they're just maintenance drugs, basically.
Huh?
Are they, what would be
Absolutely. You can call it maintenance drug, a controller. It will help prevent mast cell degranulation, but if mast cell degranulation does occur, it has no effect on the sympathetic nervous system. That's the next classification. Any questions on that? So now you know rescuers and you know controllers. Controllers maintain. I like what Kyle said. Controllers maintain. Prevent. Rescuers alleviate. Does that make sense? So, you've learned a new term. If I say a rescue drug, what kind of drug am I talking about?
Beta-2 agonist.
Beta-2 agonist.
And just, I'm not expecting you to know this. Remember when we talked about mast cell degranulation, I said the release of serotonin, the release of histamine, the release of other stuff, and leukotrienes. That's what this drug does. It blocks the release. It blocks the release of those chemical mediators, or at least tries to block. But if a person who has asthma gets into the wrong environment, like dust or whatever, because they haven't taken this maintenance drug, and wheezing ensues, everybody with me? The drug is no longer effective. Then they have to have that rescue drug, a beta-2 drug. Make sense? All right.
Isn't
Yes.
it possible, too, you could just have an acute situation where you've walked into a room full of cats and you're allergic to them?
Absolutely.
And it just overwhelms.
Absolutely.
Even if you're on
But-
maintenance.
Yeah, but even if you're on maintenance, it would have been worse if you hadn't been on your maintenance drug.
Got it, yes.
Yeah.
Yes, that makes sense.
Yeah. Yeah. But once a person starts wheezing, these maintenance drugs are not effective. They have to have the rescue drug. Okay, the next classification where we may administer probably more so in children than adults are anti-infective. La, 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 la. Anti-infective. What do you think that means? Not just antibiotics. It could be. It's just antimicrobial.
Okay.
There's 7 classifications of pathogens. I'm not going to go through those now, but it's more than a bacteria. It's viral, chlamydia, rickettsia, protozoan, fungal, all of them. So they all fall under this anti-infective. Okay? Sometimes we administer drugs. And then exogenous surfactant. That's 1, 2, 3, 4, 5, 6, 7. I'm going there. Exogenous surfactant. In cardiopulmonary A&P, what have you learned about the type 2 cell? Surfactant. And what does it do? Decreases surface tension. Well, you know what? Babies are born, preemies. This is why we're concerned about preemies. Not so much that they have little tiny feet or whatever. It's because their lungs may be underdeveloped. And so preemies born too soon are born with a lack of surfactant, type 2 cell. So if they don't have surfactant, then their lungs can't decrease the pressure to enhance gas exchange. This classification of drug does that for the baby, till they get old enough and produce enough type 2 cells. That's what it says, surfactant. Okay? These are the 7 classification of drugs respiratory therapists administer. And so we're going to go through drugs for each kind. Okay? But I wanted to get you going. And then on page 5 in your workbook, there they are again. And then the last classification, which is fine, is for pulmonary hypertension. Pulmonary hypertension is not systemic hypertension. But I'll talk to you about pulmonary hypertension in Module 2. Let me just tell you this. Whenever, whether it be a baby or whether it be an adult, you know you have 2 vascular systems. You got systemic and you got pulmonary, right? And they work together, but it's 2 different systems, right? Just like you have blood, but some of it is arterial blood and some of it is venous blood, right? All right. A person can have systemic hypertension and take an anti-hypertensive drug and they're fine. But for a respiratory therapist, now you can't see this just looking at a patient, but for a respiratory therapist, we have the base knowledge. If, whether it be a baby, whether it be a newborn, whether the baby be 3 months old, 13 months old, or whether it be somebody 93. If a person has pulmonary hypertension, meaning within that pulmonary artery, the pulmonary trunk. You all learned about the pulmonary trunk yet? Should have, gastric chain. In that pulmonary trunk, an elevated blood pressure within that pulmonary trunk means the patient is hypoxemic. Write it down. Elevated pulmonary hypertension. Ooh, look at all that. Pulmonary hypertension. What does that mean to you? Hypoxemic. So what are you going to see? Can you see that? Ebony? Okay.
Decrease in PaO2.
Hypoxemic?
Hypoxemic. They're going to be hypoxemic. And so anytime a patient has elevated pulmonary hypertension, what do you suspect if you see this? What does this mean to you? What do? You need to do for them? Give them oxygen.
Oh, oxygen, yeah.
Give them oxygen. Okay, these are just the classification of drugs. So now you've learned when a patient has pulmonary hypertension, they're going to be hypoxemic. Will you always know that? No. You may be able to do a blood gas and see the PaO2 is low. Does that make sense? But you may not know that that pulmonary artery pressure is increased. You may not know that. But I can tell you from the hemodynamic side, anytime there's an elevation in pulmonary artery pressure, that means the pulmonary artery is going to constrict and it's going to take more pressure to get the blood flow through, but the patient is experiencing hypoxemia. So is this going to affect external respiration or internal respiration? You got it. You're learning respiratory care.
Sleep apnea.
What about it?
Would that
No, ma'am.
Okay,
No.
totally.
Sleep apnea is hypoventilation and apnea. This is oxygenation. That's ventilation.
Yes.
Yes.
She said this is oxygenation, they're turning blue.
They don't have to turn blue.
They don't have to turn blue.
By definition of blue, by definition of cyanosis is decreased hemoglobin by 5 grams. Just because a patient has a low PaO2, there don't have to be cyanotic. Cyanosis means that it's bad.
So they, yeah.
But everybody that has a low PaO2 won't be cyanotic. Okay?
Sure.
Yeah. All right. Yes, ma'am.
Okay, so if you assess a patient and they are short of breath,
Mm-hmm.
you give them oxygen, you do arterial blood gas, you find out they're hypoxemic.
Mm-hmm.
What type of, is there a Is there something in that blood gas that will tell you that that patient has pulmonary
No,
hypertension?
no. It would, the pulmonary hypertension would be diagnosed by a physician.
Okay.
My point is, when you see the diagnosis of pulmonary hypertension, you immediately understand why you're administering oxygen.
Okay.
Yep.
That's my point.
Okay.
Okay? Yeah. Or you may have a resident, and believe you me, you all are going to, if you all are intimidated or you're shy, I'm just telling you, respiratory care is not the profession for you. And I'm not trying to discourage you, because you're going to have new physicians, you're going to have medical students, you're going to have residents, you're going to have a doctor who's possibly been in ER 10 years, but he is a gut doctor. They don't understand about the lungs. And they may ask you, well, okay, this patient has pulmonary hypertension, but why do you need to administer oxygen, or why is their PO 250? You need to be able to tell them why, because they not know. They really don't. Some of them don't know. And the second year students experienced that this summer. They would do rounds with the house physicians or the intensivist, and after a while the intensivist would say, okay, I don't want you respiratory care students to answer it. I want my medical students, because they knew. They jumped in, they knew. And they said they said, Miss Miller, we knew. And I said, oh, you did, how wonderful. So what I'm telling you, you're going to experience. Okay, so my associate, no, you don't have to diagnose pulmonary hypertension. We don't diagnose, but we understand diagnoses. Okay, quite a bit, you can call it before a doctor, but we don't have that authority. But we know what it is. Does that make sense? All right. Okay, so when you see pulmonary hypertension, which was that last classification, you know your patient is dealing to some extent some hypoxemia. And one way, not the only way to correct it, they may need surgery, but in the meantime, we give them oxygen. All right? Now, we haven't talked about how to give them the oxygen, but nevertheless, that's what they need. And so these drugs will help them as well. Okay, but we really may not administer them via inhalation. We may not administer these particular drugs via inhalation, but it's pulmonary hypertension. So for right now, your systemic blood pressure is one thing, but you have pulmonary pressures as well. And pulmonary pressures are 10 times smaller, or let me put it another way. Systemic blood pressure is 10 times greater than pulmonary pressures. We're talking about that 120/80. Okay, that's high. Pulmonary pressures are low pressures, very low, because the only thing going through it is the blood coming from the right side of the heart going to the lungs for external respiration, right? And the pressure shouldn't be high. But when that pressure is elevated, it's more resistance. And so this is going to interfere with external respiration, and this is why we see a low PO2 when we do a blood gas. Make sense? Okay. So now you got the 7 classifications. Moving on, let's go to chapter 2. If I'm talking too fast or you don't understand me, let me know. I try to tie things in for you so you can associate it with something. So those are the 7 classifications. You can start working on them. Okay, principal drugs of action, drug administration, pharmacokinetics, and pharmacodynamics. I'm more concerned about you knowing the pharmacokinetics, and that is 4 phases. And what are they? Admin,
eliminate excretion.
and tie that excretion in. Somebody tie the excretion into acid-base balance for me. I don't understand it. Somebody tell me.
Release of carbon dioxide and also
Release of carbon dioxide where?
from the lungs, and then excreting urine from the tissue.
Very good. Does everybody agree with Ebony?
Yes.
Yes.
Okay. And the majority of drugs, how are they metabolized? Through what organ?
Liver.
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 Not kidneys, liver. When red blood cells and white blood cells are broken down, where do they go? Liver. Our liver metabolizes just about everything in our body. When hydrogen ion, when its lifespan is up, where does it go? To the liver to die. All right, phases of drug. We take the drug, what dose did we administer, and then it goes through the pharmacokinetic phase, and then here's the clearance. Metabolism, and it's eliminated. Pharmacodynamic phase. Where did the drug go? What organ did it go to? So let's talk about a beta-2 receptor. Let's talk about SNS. Where did it go? What purpose was the drug? Well, it mimicked the adrenal glands. It mimicked the sympathetic nervous system. And we know the adrenal glands release epinephrine and norepinephrine, right? Mm-hmm. Epinephrine has the alpha, beta-1, and beta-2 effect. And norepinephrine is just alpha. It increased blood pressure. What did it do? Did it stimulate? It was sympathetic nervous system or sympathosympathetic. It stimulated. Right? All right. If it was a beta blocker, it stopped. This is just in general so you can understand. And then after it reached this peak effect, it was metabolized and then eliminated. And then for our patient who is wheezing, we need to give the drug again, right?
Right.
Not to say that the drug we gave them wasn't effective, they need more. And it continues to break down, and this is why we need to be cognizant and go back every 3 hours, every 6 hours, or whatever it may be. So your patient could be in the hospital for 3 days, and they could be pretty bad. But that 4th day, something just breaks. You know what that means? That means the first 3 days, the medication was effective. It just took a little long. But now the 4th day, just because they're not wheezing, do we not administer the medicine? No, we give it to them because we want it to be maintained. Maybe the 5th day, they'll be discharged, and they'll go home with their controllers, their anti-asthmatic drugs. And maybe we have to educate them about those drugs before they leave the hospital. Does that make sense? This is just the big picture. This is any drug administered, but in particular, think about the pharmacodynamics in relation to a beta-2 agonist. Any questions? What is the drug doing? So why do patients have to take repeated doses of something? Does that mean the first or second dose wasn't effective?
No.
Why do they have to do it every 4 hours? To maintain the therapeutic dose within their blood, right? Mm-hmm. Until whatever effect we want to occur happens. Make sense? You can unlock it. I'm sorry, I just locked it. You can unlock it. All right. Any questions with this? This is in general. But all drugs have to be what? Metabolized and eliminated. What happens if they're not metabolized and eliminated? Toxic. It'll become toxic. Too much of anything is not good, right?
Right.
Too much of anything is not good. So a drug has to do what it's going to do and then move on. Even oxygen. We don't put patients on oxygen for them to be on oxygen forever and a day. We give them oxygen when they need it. We assess them, and when they don't need it anymore, we take them off because too much oxygen will cause the lungs to shut down, believe it or not. So nothing lasts forever and a day. Yes, ma'am.
So toxic shock will lead to...
I didn't say toxic shock. I said toxic.
I'm sorry, toxic. But if the patient starts to experiencing shock from the levels?
I didn't say anything about shock. Don't put words in my mouth. We're not talking about shock.
No. I was just asking, does it lead to toxic? If they're getting...
No, lead to toxins or toxic shock. That's two different things. No. Mm-mm. If it leads to toxins, that means the patient is poisoned. The drug is no longer therapeutic effective, but just because someone has a toxin in their body, that doesn't mean it's toxic shock. No. No,
So
ma'am.
oxygen can actually be can be a toxin, right?
Yes, and when it becomes toxic, the lungs will shut down. That's crazy, isn't it?
Yeah.
But let's look at this since you asked the question. We inhale room air, right?
Right.
How much, what percentage of room air is oxygen?
21%.
All right, and the rest is what?
Nitrogen.
All right. So even though the nitrogen is not involved in gas exchange, it's there, yes?
Yes.
Okay, now, if we put a patient on oxygen, whether it come from an E tank, an H tank, or this, what's the percentage? 100%.
100%.
Now, our lungs are accustomed to 79% nitrogen, right? If we give 100% oxygen, it's going to wash all the nitrogen away. And as it washes the nitrogen away, it's too much oxygen. And when something is too much for you, when it turns you off, what do?
Turn away.
You turn away, you walk away. The lungs will shut down. It'll cause atelectasis.
Does it have to do with, like, does it cause too many, like, chemical reactions to happen?
No, it just causes O2 toxicity. It will cause all the alveoli just to shut down and close. And then you've defeated your purpose, because what was the purpose of giving the oxygen? To increase the PO2. Now you've given so much oxygen, the PO2 starts to drop. And that's called refractory hypoxemia. That happens from a therapist not assessing a patient and giving too much oxygen. Too much of anything is not good for you. So oxygen is a drug. So we have to monitor how much oxygen we give a patient, and when they no longer need it, we take them off. Oxygen, although is a gas, is a drug. It has to be an indication for the drug. It has to be goal for using the drug. And we as therapists know how to assess. That's why I've gone through the 2 ways oxygen is carried through the body.
So that's why everybody just doesn't get 100% oxygen right from the get.
You bet your sweet bippy that's why. Because you'll cause O2 toxicity and their lungs will shut down.
Oh my God, that could kill them.
Absolutely. Absolutely. We don't know what we're doing. We can kill a patient giving them too much oxygen. We can teach a 10-year-old, a 12-year-old how to set it up and administer it. But do they know why they're administering it? And do they know the side effects of it? Make sense? That's why you're going to sit in this classroom for 2 years. And you're going to learn everything you can, and then you'll be ready. All right. Drug administration phase. We went through this very quickly. We went through enteral, that's GI tract, oral, NG tube. Our drugs are not enteral. We administer via inhalation, and that's parenteral. And some of you, when I went through this before, you said, the mouth, the oral cavity, is shared by both the GI tract and the respiratory system. But just because we administer orally or through the mouth, it's not going into the GI. It's not going into the stomach. So our inhalation is parenteral. Any drug, IV, intramuscular, transdermal, inhalation, topical, this is how we administer. Okay? Everybody knows that, right? All right. Here we go. Devices for inhaled administration. A vaporizer, such as a room humidifier. We don't set those up, but it's good to know. And you'll learn more about humidity and aerosol in Module 3. Then, I want to say maybe 20, 25 years ago, and I should have brought, I'll bring it Tuesday, is an atomizers. Do some of you ladies, or maybe not you, because you all are young, and I didn't even use it, but my grandmother used it, or you can find them at Macy's and Nordstrom's, the pretty perfume bottles where you can actually take the perfume and pour in and squeeze the bulb and you see the dispense. Okay, that's an atomizer. At one time, we used atomizers to dispense our beta-2 agonist. But we got a little smarter in respiratory care, and we quit using atomizers because of the condensation and rainout. And what I mean by that, the atomizer produces particles, but they're different sizes. That's what an atomizer do, okay? The atomizer produces particles and wonderful just to put on some perfume. But far as inhalation, let's think of this being deposited into the respiratory tract. The condensation that I have, the larger the particle size, the sooner it rains out. And when I say rains out, the sooner it's deposited. So the very larger particles never get into the bronchi where the bronchoconstrictions are. They rain out in the mouth, in the back of the throat, and the larynx. That's not where the bronchospasms are occurring. Does that make sense? Mm-hmm. The smaller particles only are the ones that get to the periphery, or let's say that 10th through 19th generation of conducting airways. So this is why we don't use atomizers anymore, because the particle sizes are not uniform. And the larger the particle, the sooner it'll rain out in the airway. And we don't need medication in our throat or in our larynx. We need the when I say we, the individual, the patient needs the medication to be penetrated into those bronchi, right? Right, left main stem bronchi, generation 1, terminal bronchioles, generation 19. That's where we need the medication to get to. And so the particle sizes must be smaller. So this is why we don't use the atomizer anymore, because we found out we were getting a lot of rain out, and a lot of the medication was only being deposited nasopharynx, laryngopharynx, and that's not far enough. Okay, so we still use the pretty bottles for perfume, you know, but now what we use nebulizers. And an SVN stands for small volume nebulizer. Small volume nebulizer. And LVN stands for large volume nebulizer. I never write any of this out, because you'll see doctors just say aerosol treatment. Aerosol treatment, you know, to give a small volume nebulizer. All right, why a nebulizer? A nebulizer delivers uniform particles. Uniform particles. What do I mean when I say uniform?
They're all the same size.
Right, they're all dressed alike in their beautiful blue that has Respiratory Care Baker College on it. And we're ready to go to hospital and strut our stuff. Right? Good. So an atomizer, the particles are not uniform. And so we found out, that doesn't always get to the small airway. That may not make it down to that 11th through 19th generation of bronchi and bronchioles. Make sense? Mm-hmm. So we stopped using the atomizer, and now we use nebulizers. And I'm not going to tell you why, because we'll learn that in practice and procedures. But a nebulizer delivers uniform particles. So it doesn't matter whether we're delivering a beta-2 agonist. It doesn't matter whether we're delivering an anticholinergic drug. It doesn't matter whether we're delivering a corticosteroid. The particle sizes are uniform, and that's better deposition, meaning that particle sizes will go further into the airway, and it will penetrate where the airways can absorb them, and then consequently we get bronchodilation. Make sense? Mm-hmm. So in respiratory care, in Module 3, in Practice and Procedures 1, we're going to go through humidity and aerosol. And so these are called aerosols, whether it be small volume or large volume. I'll talk about that in Module 3. Ms. Pope is going to show you in lab. A nebulizer is a nebulizer, but we use a small volume nebulizer to deliver aerosolized medication. small volume nebulizer is to deliver aerosolized medication, the drugs that we're learning about. Large volume nebulizer delivers high humidity for humidification. Anybody ever had a dry cough and it hurt when you coughed? That's because you had a humidity deficit. Where'd that humidity deficit come from? Well, what's the function of your nose? To warm and humidify, right? For whatever reason was going on, your nose didn't humidify. When your nose does not humidify the gas that we inhale, your airway dries out. And your airway is full of epithelium, and epithelium cells, what's the characteristic of all epithelial cells? You all had A&P 1 and 2. What's the characteristic of all epithelial cells? They're what?
They line airways, vessels.
But what's the characteristic of all of them? You're correct. What's unique about them? They have mucus. They're all moist. Whether it be in your anus, whether it be in your ear, whether it be in your vagina, whether it be your rooter, wherever, your eyes, your mouth, they're all moist. Now, our airway, believe it or not, is moist. Why? Because of our nose. And then you got a cold, or you have bronchitis, or you have something, a deviated septum. Think about people now, you know the three functions of the nose. Think about people that have a deviated septum, meaning their nose bone, the septum, deviates or twists. They probably have dry coughs sometime. And why do they have dry coughs? Because their nose is not adequately humidifying the air that they inhale. And that can be irritating. And they'll go to the doctor complaining about a dry cough when that's really not the etiology. The etiology is the deviated septum. So they'll have a humidity deficit. And and my point, going back to humidity and aerosol, you as a respiratory therapist may not necessarily have to administer oxygen, but you've got to provide high humidity to those nostrils while they're healing. Does that make sense? The nose is part of the respiratory system. And you're going to see that. Okay. So nebulizers will deliver aerosolized particles, your beta 2, your anticholinergic. Then the meter dose inhaler. The handout that I gave you with the picture of the drugs, those are these are all MDIs, meter dose inhalers, or DPIs, dry powder inhalers. The handout that I gave you. And look up here. What does this say? Relievers, rescue bronchodilators. We just went over that this morning. See that? Means they're short acting. See them? Mm-hmm. All right. And then see below it, what is that word? Controllers. Controllers will not do what? Controllers will not reverse bronchospasms immediately. Controllers are maintenance drugs. So all these drugs, patients can go home with. 25, 30, even before my time, 40 years ago, asthmatics stayed in the ER. Stayed in the ER because they didn't have access to drugs like this. Now they have access to drugs like this, and it's respiratory therapy's responsibility to educate the patients and make sure that the patients know how to adequately take the drug. And if they can do that, they'll stay out of the hospital. Okay? So MDIs or DPIs, that's what these are on your sheet. Any questions? This is how we deliver drugs. More common are the nebulizers. That's what we'll do if the patient has to come to the hospital. And then patients will go home and be on these drugs. So, why do we have to learn these drugs? We may not necessarily administer them because the patient has an MDI in their pocket or a DPI in their pocket. We need to know what they are so when they come to the hospital, we can identify what they're taking at home. Make sense? Mm-hmm. Yes.
So you could give a fast-acting bronchodilator and a controller, both through a meter dose inhaler and DPI. That's just
Not a controller.
no.
The controllers are here. No. Patient will go home with a controller. All of these are controllers.
Okay.
You're going to give your epinephrine, your albuterol, your levalbuterol, and your Atrovent. You can give those as a rescue drug in your small volume nebulizer.
Okay. Okay.
We've evolved.
Okay.
Okay? Does everybody understand what I'm saying? You may have a patient say, you know, I take Asthmatic at home. What is that? And you're a respiratory therapist, you need to be able to tell them what Asthmatic is. And you don't have to talk about increased 3,5-A and P. You don't have to do all that. You need to be able to take this language, this dialogue Kathy Miller is expecting you to use, or the dialogue that you would use with a physician. You need to be able to take that hat off and then now translate it to where an individual, not insulting anyone's intelligence, but you need to be able to take that language and then explain it to an individual that has no concept of what a PNS and an SNS is. And tell them, instruct them how to take the drug and why it's so important to take the drug. Okay? This will keep asthmatics out the hospital. It's our responsibility to do that. Okay? All right. Some of you may want to become asthma educators. That's an extra credential you can earn after you become an IRT. You can do that if you want to. This works solely with asthmatics. Okay, any questions with this? There's your SVN, LVN, MDI, DPI. Patients will go home with these. Patients can come in the hospital with these. But whatever they're on, you need to know what it is. You need to know what it is and tell them. Or if a patient's on a corticosteroid, and I'm not expecting you to know this now, you know they're on a corticosteroid and you ask them, are you rinsing your mouth after you use this medication? And they say, no, no one ever told me. Well, then now you tell them why it's important for them to rinse their mouth after they use a corticosteroid. And you're going to know they're not rinsing their mouth because you're going to see their teeth are yellow and some of them are turning brown. And it's not because they have gangrene. It's a side effect of the drug. And we, as therapists, need to know that to educate our patients. Yes?
I have a purple inhaler, but it was like one where you do an inhaler every day.
Mm-hmm.
And they told me to make sure I brush my teeth like once or every day, but they told me I get a yeast infection in my mouth. So I did.
That's a side effect of corticosteroid. Babies get it. It's called oral thrush.
Mm-hmm.
Thrush.
That's a side effect, and we as therapists know that. And I'll explain to you when we get there why. But we need to know. Ask them, are you brushing your teeth? Are you rinsing your mouth? How are you taking these two drugs? Take the bronchodilator first, then the corticosteroid. But what's great now, we now have them, pharmaceutical companies have now put both drugs in together, which makes it easy. Because particularly the kids don't do it, or the kids might be in school and maybe they can't get to the restroom, or the teachers won't let them have their, certain circumstances. So we're improving, we're evolving as we go. Make sense? All right, we've gone through that. I'm not going to go through that. All right, pharmacokinetic phase. Local versus systemic. What does systemic mean? And I'm going to stop. System-wide, local. So what's the advantage? There is an advantage to us administering drugs, inhalation.
It contains the area we want to treat.
Absolutely. It goes directly to the lungs. It's quicker acting, and it's less side effects. It's quicker acting, less side effects. Distributed faster, quicker onset, and fewer side effects. That's the advantage of something local. And when I say something local, that's the advantage of us administering drugs via inhalation. And so now, does that make sense why we call the drugs you're learning epinephrine, racemic epinephrine, albuterol, levalbuterol, rescue drugs. We administer them via small volume nebulizer, inhalation. This is distributed faster. Remember, the patient is wheezing. Garrett's dealing with bronchoconstrictions. Quicker onset, meaning it's going to work faster, increase 3,5-AMP, work faster, and it's fewer side effects. Okay? It says it's good for bronchial smooth muscle dilation. What's bronchial smooth muscle dilation? Bronchodilation. Okay. And airway clearance of secretions. Respiratory care, we're not only concerned about bronchoconstriction, but we want the airway to be cleared of secretions, because we know what is one potential cause of bronchoconstrictions? Excessive secretions. So what we want to do, yeah, we want to give the oxygen, yeah, we want to give the bronchodilator, but you know what's going to be important for you guys? Those that are conscious, after you administer these therapies, patient hopefully can do it. They may not be able to do it. You want to know, can they cough? Can you cough? And they'll attempt to cough. And what we want to see, it sounds gross, but what we want to see secretions. And more secretions I see in tissue, I know that the airway is better off. And some patients are just going to love you because they just going to think you're so cute. They have never seen a bald-headed black man. And you ask them to cough, and they can't do it. But you go back 4 hours later, look, I saved this for you. And you just had lunch, and you're going to see a hanky full of secretions. And you thank them for it. Because maybe they couldn't do it when he was there. But they did it a half an hour later. Ooh, and I'm going to save these secretions. That's what's going to happen. So like I said, we don't empty bedpans, but you're going to need to know what secretions are. And it's good if we can get a patient to promote and facilitate a productive cough. So yeah, we're doing this stuff, but after we do all this wonderful stuff, can they facilitate a cough and we can get some secretions up? Okay, because those excessive secretions are essentially interfering with ventilation. Does that make sense? Okay, I'm going to stop there. Any questions?
No, well, the doctor usually will order the sputum samples and to look for that, right?
Well, to look for culture and sensitivity to see if it's a pathogen in the secretions.
Okay.
If they suspect that. And then if it is a pathogen, it's one kind of pathogen if the secretions are yellow.
Right.
It's another kind of pathogen if the secretions are green. And it's something else if it's brown.
Right.
And we'll learn that next semester.
All right. Sounds good.